Let's go to one of our major stories, which is our topic for today. And we're talking healthcare, primary healthcare, which, of course, you know, is the backbone of a strong and healthy nation. Well, it provides essential medical care to most people, helping to prevent diseases and promote wellness and treat common illnesses. In Nigeria, while there have been improvements in recent years, primary healthcare still faces many challenges that keep it from being as effective as it should be. Well, joining us from our Abuja studio is the Executive Director of National Primary Healthcare Development Agency, Dr. Muyi Aino. It's good to have you join us on the program.
Thank you very much. It's a pleasure to be here.
First off, compliments of season. Before we get into the conversation, talk to us about what we've seen, the improvements we've seen so far in primary healthcare. There are still a lot of challenges. Just recently, I was in Cross River State, and I could hear the Director General, of course, there, that's talking about how it was difficult for them to get vaccines, citing logistics issue, saying that it's not that there are no vaccines, but that there are logistics issues. But first, can we start from there and talk about what improvements you've seen in the last 1 year?
Thank you very much. I think I will speak broadly to some of what our focus has been over the past year and what improvements have been, but I'd like to start with the issue you raised around vaccine logistics. I think one of the things that we saw when we came in was there were, not too frequent, but more frequent than we would like, occurrences of vaccine stockouts in the front line, meaning at the facilities level, because of logistics issues. Sometimes it's because there's no cold chain storage at the last mile. Sometimes it's because the ability of the facilities to get it from the state stores or from the local government stores was impeded. So there are two specific things that we initiated and are implementing with our partners. One of them is really a drive to increase the penetration of vaccine cold chain equipment. So we're buying about 1,700 units that are going to be in the priority facilities where there are the biggest gaps, PHCs that will be solarized, and this will be able to store their vaccines where people can access them. That's well underway now, and that's part of the initiative, the drive to improve primary healthcare services. The second thing is also what we call direct delivery of vaccines, which has an acronym called DRIVE, which basically is the states. We're working with the states to take charge of moving vaccines directly to these facilities. Some of that is the government that is doing it themselves, funded from the federal government, but also with some partner resources. Some of it is also done through outsourced services with logistics companies or transporters that are local, where periodically you take vaccines from the state store directly to the LGA store, from the LGA store to the health facilities, so that the issue of stockout and inability to get the vaccines is really getting out, is really reducing. So that's there. Now, if I could speak a little bit more broadly to the progress that we have made in the PHC system broadly this year, I think one of the things that the President committed to was really to improve the availability of good quality primary healthcare services for Nigerians. And, under the leadership of the Coordinating Minister for Health, Mohamed Pate, we really started to revitalize our PHCs. And I can tell you that this year so far, we have completed over 300 facilities, 309, I believe, and another over 300 is almost completed, is already being revitalized. And the President and the Minister have also, through the goodwill and engagement with partners, mobilized resources that are with the states right now, and the contracting is ongoing for another 3,018 facilities. So all in all, by the time we finish 2025, there will be an additional over 4,000 facilities that have been moved from inadequate to having adequate facilities in terms of infrastructure, in terms of the workforce, in terms of the equipment, reliable solar power, and even accommodation in rural places for health workers to stay. Thank you.
I hear you, and of course, it's just like you said, 309 healthcare facilities already completed, and we're hoping to see more facilities being renovated and rehabilitated. But in most of these healthcare facilities that we've visited over the years, the problem is still going back to the vaccines like that you talked about earlier, is the fact that there are no facilities or no cold chain equipment to actually store these vaccines, and that's why you have people not receiving vaccines on time, particularly infants not receiving vaccines on time. But talk to us about really what you're doing to bridge that gap and, of course, encourage more persons and close that gap of the zero-dose children that we have in the country, because it's one of the highest in the world, right?
Yes, we do have an unacceptably high number of zero-dose children, which is the children that have not received any of the routine vaccines that they should get. But there are a myriad of factors that are available, that are responsible for this. One of it, of course, is the availability of the vaccines in the front line itself. The second is the ability of the healthcare workers to reach the people that should be vaccinated and get them vaccinated. But of course, not to be trivialized is also the demand side issues, which is attitude and acceptability of vaccines by the communities. We have mapped the zero-dose locations, like you said, across the country, and we have identified 100 zero-dose LGAs and mapped and initiated something called the Identify, Enumerate, and Vaccinate. Basically, all of the vaccine-eligible children in these priority locations, who are their parents, where do they live, what is their vaccination status, we know who they are, we can identify them by name, and that way we can follow them on a case-by-case basis to remove the reasons or address the issues why each of them is not vaccinated. And I can tell you that over the last year, we have been able to, through this initiative, vaccinate 54,942. That's almost 55,000 zero-dose children. So we're making, in just these 100 LGAs, so we're making some progress against that. I think, again, like I tried to highlight before, for the delivery side, we are really working with the states to improve the quality and availability of cold chain equipment in the front lines, but even going to the transportation, appropriate transportation of vaccines through the direct delivery program that I talked about. And they are even tracked, because it's one thing to move vaccines, it's one thing to store them, but it's another to make sure that there are no temperature excursions. You have to keep them tightly within a range of temperature. So we're using remote temperature monitoring devices that are provided with government resources and with partner resources again to monitor these vaccines, so that when they do get to the children and they are administered, they are potent and of high quality.
And just going from your line of thoughts, which is the role of states in ensuring that the national objective of expanding the primary healthcare facilities is achieved, what can you say about the 36 states and how well have they been able to key into the agenda of the national body?
I think there are two pieces to the question that you've asked. I think in terms of keying to the agenda of the federal government, of course, headed by His Excellency President Bola Tinubu, I think there was a compact that the president had the foresight to institute with the states and partners, which basically is an agreement that aligns on what are the priorities that we will all focus on and what are the different roles of the different partners. All the 36 states and the FCT are signed to that, as are the major development partners. And I think the governors have, in fact, really stepped up to try to drive. Immunization is one of the priorities, so reducing zero-dose children and increasing coverage of basic vaccines, are some of the objectives in the compact. And the states are stepping up. They are, of course, as you would expect, when you have 37, there are different levels, but I have to say that the engagement of the Nigerian Governors Forum, the Health Commissioners Forum, and even the Forum of Executive Secretaries of the State Primary Healthcare Development Agencies, and even ALGON, with the new Supreme Court ruling and ALGON getting more involved, even they have expressed a lot of interest to be part of this drive and to achieve these vaccination goals.
And I see that there's something you call the PHC Leadership Challenge Award, won by some states. Can you tell us a bit about that? And we see that Anambra State, of course, came up tops Recently, you gave the governor of the state an award of $700,000, right, from the Bill and Melinda Gates Foundation. That's for PhD development in states. Talk to us more about that, about the criteria behind picking or selecting a state for this particular award.
So the Primary Healthcare Leadership Challenge is really a partnership between the Federal Ministry of Health and MPHCD on the one hand, the Nigerian Governors Forum on the other hand, but also partners UNICEF with funding from Bill and Melinda Gates Foundation. And it really is an attempt to foster healthy competition between the states to achieve some commitments that were made and termed the Seattle Declarations of 2019. And those declarations really are anchored around certain leadership actions, with the belief that, if there are specific leadership actions by His Excellency's governors of states or close designates deputy governors, things around prioritization and financing of immunization, actions around, taking a stand and getting involved in the supervision personally by these leaders of PHC interventions in the field, other actions around accountability, at the leadership level, that they would translate to better programs, better quality of services, and better coverage of primary healthcare interventions, as well as reduced morbidity, reduced sickness, and reduced mortality in our people. So the way it works is that, the states will self-report. We did the second one this year, by the way. This is the second award. The first award was last year. And each year, the states will self-report on a quarterly basis on these pre-defined indicators. And then we had, hired through a partner. The partner had selected an independent verification agency who then went out to verify when a state says this has been done, was it actually done? Is there acceptable evidence that it was done? And then an independent judging panel again, which is a collective of academics and seasoned professionals in the field who are removed from the government, who are removed from the PHC system as it is now, will look at this and determine who are the winners along a number of dimensions. So this year what we had was we had a best state in each of the 6 geopolitical zones. We had a first runner-up, which is the second state, and then we had an overall best. And in addition, we also had one state that had special recognition for an innovation that was remarkable when you stack them against each other. So all the other pairs. So Anambra, of course, was top in the southeast, was top nationally and by extension top in the southeast. I believe that was seconded by Abia in the southeast, and then you have, again, other states that came first in their zone. So that's really how it works. And what we found is that the engagement and interest and excitement around this, not just because of the money, because there are financial incentives attached to the winning. I think the national winner gets 700,000. Each zonal winner got 500,000, I believe, and the first runners up got 400,000 US dollars each. That's in US dollars, by the way. So this is good resources that the states can then replow into their primary healthcare systems. But I think beyond that, just the sense of seeing the benefit of the efforts that they're making, I think, has been a source of motivation for these leaders. And we're happy with the progress that we have made with the Primary Healthcare Leadership Challenge.
Another major issue really is the healthcare workers. I know we've talked about brain drain and about how healthcare workers are moving in droves into other countries, and about how, poorly paid they are, really. Because when you speak with some of these health workers at the various PHCs we have across the country, they will tell you they're not being paid well. But talk to us about the kind of investment that's going to come in the next 1 year. Should they be expecting any kind of pay rise because of the kind of work they do? Particularly a story that I heard a couple of weeks ago was this particular matron who most of the time she's always on duty alone, and then she uses a phone touchlight to help a woman give birth. And it speaks to the deficiencies at the various healthcare facilities and how important, or how it's expedient it is to upgrade some of these facilities. But what is really being done to help these healthcare workers get good pays for the work that they do on the field?
I think the availability and competence of health workers is a critical factor, very, very important factor in making quality healthcare services available for people. Now, when you look across the health system in Nigeria, yes, of course, there are gaps, significant gaps in our human resources for health, and that's due to, chronic underinvestment historically, but also just improved global mobility. I think it's important to establish sometimes that, of course, we're not happy with the fact that a lot of our health workers have moved out, but this is not unique to Nigeria. There's a lot of health worker mobility, just people moving around generally, but health workers in particular across many countries, and you find a lot of people moving from poorer countries to richer countries in the desire to make their personal lives better. And that is all well and good. Now, that's due to a number of factors. I think salaries or income, as you put it, is one of it. And I'm sure you are aware, as we all are, that the president recently approved a pay raise for all people who work for government in terms of resetting the minimum pay. Now, in addition to that, there are specific incentives that go to health workers, and the Federal Ministry of Health is also really looking at, unique interventions that can be done to alleviate some of this, but make it sustainable. One of the things that we should always remember is that you're working within a system, within a framework, and you don't want to establish mechanisms that you then cannot sustain and create more problems for you down the road. But I think there are a number of other important aspects that affect the retention, that influence retention of health workers. This has been well published. I personally researched this many years ago, but if you also talk to the health workers now, one of it, a major part of it is really just the working environment. Do they have dignified work tools and environments to work? Is it safe for them to work? And do they have enough hands to work? And those are the things that we're trying to tackle by improving the quality of the primary health centers, by making sure work tools are available, by making sure that the commodities, the medicines and the medical supplies that they need to take care of basic services for their patients are available in the facility. It's a journey because, frankly, we're coming from a low base. When this government came on board, I think the level of performance, we set a baseline, and the level of performance was very low, and you have alluded to some of that. But all we can do is move as fast as we can to try to improve things and try to get better care to Nigerians, and that's what we are doing. So we're improving the infrastructure, we're improving the commodities, we're looking at things around the welfare of workers in terms of salaries, but also other incentives. At the part of the Basic Healthcare Provision Fund, for example, in the next phase, the BHCPF 2.0 that will be kicking off Q1 next year, we're building in retention incentives for skilled birth attendants that work in rural areas that have stayed there for extended periods of time, just as a matter of making things easier for them. We are also including residences or accommodations for health workers that are working in rural areas for their own safety. Part of the challenge is when you have to go back and forth every morning and every night between where you live and where the facility is. Sometimes there's cost associated to that, there's physical stress associated with that, but there's, frankly, in many areas of the country as well, even physical risk, especially when it's late at night and people are moving around. So all of that is being factored into all of the things that we're doing to try to make life easier for these heroes of the health sector, because really these are the real heroes, the health workers.
About a month ago, the Federal Ministry of Health had launched a project which is to, of course, reduce maternal mortality. It says it's the Maternal Mortality Reduction Innovation and Initiative Project. And you say this project is, of course, aimed at drastically reducing maternal mortality and childbirth complications in Nigeria, which brings us to the costs of healthcare. There's the cost side to it. I know that you've been talking about how you want to shore up the facilities, but then the cost on the people it's a bit on the high side, particularly when you take a look at the present economic situation we're in. Talk more about this project and how it will help women, particularly those in the rural communities. Do they have to be part of the insurance scheme?
So I will answer that. So in some regards, yes, but also no. So there are certain things that we provide for free as a government, as part of the President's Renewed Hope Initiative, as part of the Basic Healthcare Provision Fund. It's free when you go to a primary health center as a pregnant woman, as a child under 5 in many places, because what we're doing is investing in service readiness. Some of the inputs is aimed at helping these facilities service the patients free. But in addition to that, there are certain services that the basic provisions don't cover. The NHI, National Health Insurance Authority, also provides insurance through the Vulnerable Group Fund for poor people that covers some of this. But things like emergency cesarean sections were not covered. But what the MAMI covers, you know, the program that we just launched that you just mentioned, what it does is, in addition to guaranteeing from beginning to end good quality antenatal care services, basic delivery services, all the diagnostic tests, all the commodities that you need as a pregnant woman, but also if you do need emergency maternal services, whether it is bleeding after birth, postpartum hemorrhage, whether it is the need for emergency cesarean section, whatever else. And in fact, newborn resuscitation, because we want to save the lives of the mothers, we also want to save the lives of the newborns. You know, that's what the success is, and that's what the President is trying to do. So those are the things that the program guarantees. And what we did is, again, this is going to cost a lot of resources, right? And you can't really go everywhere at the same time. So what we did was to say, where do you start from? Ultimately, the MAMI will cover everywhere, but where do you start from? So we did the analysis based on data that we have and identified 172 local governments across 33 states. So fairly well spread out across the country that contribute more than half. Remember that we have 774 local governments. So if you have 172, you know, which is less than 10% of that, or less than 20% of that, contributing, actually just over 20% of that, contributing more than half of deaths. You know that those are places that we should pay attention. And we have already started the process of engaging, and we have done a diagnostic in 2 states to try to understand what are the specific local drivers. Again, one community, Nigeria is very diverse, so one community doesn't always equate to the other. The challenges, broadly, we know, but some of the other nuances, you have to go to the ground, you have to engage with the communities, with the women themselves to understand why, what barriers they have. And it ranges from cost of transportation to the attitude of the health workers, to access to the commodities that are important, you know, even when the health worker knows what to do. And we are trying to bridge those gaps, again, starting from these 172 LGs, but ultimately expanding across the country.
I think, like we say, we need to follow the money, right? We see that the President has budgeted really well, you know, for the healthcare system. We see a 402 billion naira for infrastructure investments alone in the health sector. Although this might not be enough, really, if you take a look at the number of healthcare facilities we have across the country, just like you said. But how do we track the money? What's the mechanism you have in place to ensure that these monies go to the right places? In 30 seconds, if you could answer that for us.
I think one of the core pillars of the health sector strategic blueprint is around governance and accountability. And a big part of that is accountability for the resources that is put into us. We are fortunate, like you mentioned, that the President prioritizes health and has increased the health budget in this year against last year by well over 50%. And even last year, you know, was multiple times of 2003, actually. No, yes. So 2025, sorry, is more than 50%. 2024 was 2 or 3 times 2023. So we have to be good custodians and use these resources very well. And they were doing a number of things depending on where you are. So for the Federal Ministry of Health, they have their mechanisms for accountability, their oversight. We have a ministerial oversight committee that sits every quarter, for example, that starting with the basic healthcare provision fund that goes through 4 gateways where we discuss what have you spent, what has been disbursed, through the gateways, including National Primary Healthcare Development Agency, to the states. Where did the money go? How much of it got to the facilities? What did they do with it? And even at the facility level, what are they doing with it? Part of that we started doing manually, but we're also digitizing now. We now have the beta version of a health facility financial management tool, where from the beginning, from the federal level up until the health facility level, you can track every naira. We also have engagements with CBOs. We have organizations like Budget that we're working with, who are also tracking with us and giving us feedback. We can't have our eyes in every corner of the country, but everywhere where there is some sort of mishap or suspicion thereabout, it is flagged and we act on it. One of the things that we also try to do is be transparent to Nigerians, right? We understand the starting point, but as we're building up. So on the primary healthcare side, for example, we have built a dashboard that is freely accessible to all Nigerians. If you just go to https://phc.mphcda.gov.ng, you can track the work we're doing on PHCs. You can identify the PHCs near you. You can check if we say we have spent money there, whether in fact what we claim is there. And if it's not there, there's a mechanism to feed back to us on the same platform, and we take action. So all in all, we have institutional partnerships with the ICPC, at the ministerial level, to track all of our investments. We also have a very vibrant civil society who have now heard of the substantial amount of resources that the president have invested and are going to track with us. Yes, thank you very much.
We're going to be tracking with you as well. Thank you so much, Dr. Mui. I know the Executive Director of the National Primary Healthcare Development Agency. We're hoping to see more improvements in rural communities particularly. Thank you so much for talking to us on Business Nigeria.